It's Patrick Hutzel from IntensiveCareHotline.com, where we instantly improve the lives for families of critically ill patients in intensive care so that you can make informed decisions, have peace of mind, real power, real control, and so that you can influence decision making fast, even if you're not a doctor or a nurse in intensive care. This is another episode of Your Questions Answered, and in last week's episode I answered another question from our readers, and the question last week was: my dad is 5 days in ICU with a stroke and is ventilated. Why are they in a hurry to push him out to LTAC? You can check out last week's question by clicking on the link below this video. In this week's episode of Your Questions, I want to answer a question from one of my clients, Ashanti, as part of my one-on-one consulting and advocacy service. Ashanti's dad is in ICU with a stroke and is on a ventilator. Ashanti is asking, how long does it take for her dad to be weaned off the ventilator? So today's episode is: my dad is critically ill in the ICU, and how long does it take for him to be weaned off the ventilator? And I'll read out the email exchange with Ashanti and myself. Hi Ashanti, he will only be able to come off the ventilator if he can breathe spontaneously. The ventilation mode before extubation is called CPAP, also known as continuous positive airway pressure or pressure support ventilation mode. Keep asking for the following: what is the actual ventilation mode? What is the ventilator PEEP? PEEP stands for positive end expiratory pressure. What PEEP basically means is when someone is ventilated, it's positive pressure into the lungs, right? When a healthy person breathes, then it's negative pressure into the lungs. But when there's positive pressure into the lungs because someone is unable to breathe, there's a risk that at the end of inspiration, when people get the air pushed into the lungs with the ventilator, that the lungs collapse. And the PEEP prevents collapse of the lungs by maintaining a positive airway pressure at the end of inspiration, at the end of expiration, right? Because otherwise the lungs would collapse. Okay, next questions. How much pressure support is he on? What are his tidal volumes? So the volumes inhaled on inspiration and on expiration. So volumes are generally speaking around 7 to 10 mils per kilo. So for simplicity, if someone weighs 100 kilo, 7 to 10 mils per kilo is anything between 700 and 1000 mils per breath. That would be adequate for someone's lung capacity according to their weight. Next, what are his minute volumes? The volume of air that can be inhaled minute volume, or exhaled minute volume from a person's lungs in 1 minute. And that's usually calculated by breaths per minute times tidal volume. So again, for simplicity, 10 breaths per minute times 700 mils is 7 liters per minute, or 7,000 mils per minute. Next, what is the ventilator's FiO2 fraction of inspired oxygen? Room air, the air that you and I are breathing, is 21%. Now, if someone is on a ventilator, chances are they need more than 21% room air. They need 25%, they might need 40%, they might need 100%, it all depends. What is the result of the most recent arterial blood gas? When someone is on a ventilator, it's always good to get an arterial blood gas to see whether mechanical ventilation is appropriate and effective. You get oxygen readings in the arterial blood and you get carbon dioxide readings in the arterial blood. And if those levels are physiological, then you know that mechanical ventilation is efficient and adequate. Next, does he have a good strong cough? Next, how frequently are they suctioning him? Is he obeying commands? For further reading and as a guiding article and video, you can click on the link below from our website at IntensiveCareHotline.com, how to wean off ventilation and tracheostomy step by step. And I'll put a link below this video. So if you're watching this on the website, just scroll down in the written version of the blog and read there, or watch the video. Now, Ashanti writes back: hi Patrick, as per a brief phone discussion today with one of the nurses in ICU, she mentioned that His ventilator mode is PRVC, pressure regulated volume control. Other parameters are as given before in my previous email. PEEP or positive end expiratory pressure 6. Fraction of inspired oxygen, FiO2 35%. Breathing rate or respiration rate 16 breaths per minute, tidal volume 400 mils. I couldn't get the minute volume as the nurse was not in his room. Currently he seems to be not responsive to any commands and only to pain stimuli movements, so coughing might not be good enough. Now, coming back, you couldn't get the minute volume. I can get the minute volume for you purely by you giving me those numbers. If the breathing rate is 16 breaths per minute and the tidal volume is roughly 400, it's 16 breaths per minute times 400. So that would be around 5 liters, roughly. 10 times 400, no, it's more than that. 10 times 400 is 4 liters and 6 times 400 is 24. So around 6.5 liters minute volume. As per nurse on duty today, he did undergo a spontaneous breathing trial, SBT, and could last only for about 20 minutes before back on full ventilation support. He's hemodynamically stable, no fever, on his regular medications. Thank you so much, from Ashanti. Here is my response. Hi Ashanti, as mentioned, as long as he is in a controlled ventilation mode, he won't be able to come off the ventilator. An arterial blood gas while he is on a spontaneous breathing trial would help tremendously to determine how far away he is from having time off the ventilator. Any questions, please let me know. Ashanti writes back, hi Patrick, thank you so much. Do arterial blood gas parameters show up on the ventilator, or is it through a separate instrument needed? The intensivist doctor did not answer me properly last time. Not sure if he's making good progress in his spontaneous breathing trials. Weaning process in his case might take longer. It's preferable to be in a hospital setting if he's in the weaning process, correct? Is it better to talk to a pulmonary technician or doctor about the weaning process in his case? I have a feeling that they're less inclined about weaning him and removing COVID restrictions than keeping his vitals stable. Let me know your thoughts. Thank you, from Ashanti. Hi Ashanti, per your last email, arterial blood gas results cannot be seen on the ventilator. Arterial blood gas is a blood test to determine current oxygenation, ventilation status of your dad, which is important for weaning, and they're using a separate machine to get the result of it. You can have a look at this article below to know more about arterial blood gases. We have written extensively on our website about arterial blood gases, and I have put a link there. Definitely you can ask the respiratory therapist, the ICU nurse, or the doctor if your dad is already on the weaning process. They need to explain to you what progress your dad is making with the weaning. You're also asking, is it best for him to be in a hospital setting for weaning? Look, it depends. As you might be aware, we're also providing intensive care at home services, and with intensive care at home, we're certainly weaning patients off the ventilator at home as well. So it really depends. Ashanti writes back, hi Patrick, my father has been in intensive care now for the last 17 days. He was diagnosed 20 days ago for COVID and treated initially 4 days for the same. As you know, that he had the brain hemorrhage and is on a ventilator with tracheostomy and the feeding tube for the last 17 days. They had mentioned they would be de-escalating to move him to the non-COVID intensive care unit tomorrow. They have been trying to wean him off the ventilator for the last week or 10 days. He made some progress. 2 days he did with continuous positive airway pressure, or CPAP, also known as pressure support ventilation, for 6 to 7 hours before he went back on the ventilator, and yesterday could last for only about 4 hours. My dad also has atrial fibrillation, also known as AF, and his heart rate was higher, so they did not do his spontaneous breathing trial today. The doctors would have a meeting with me tomorrow to discuss further steps towards discharge. Not happy if they are talking about discharge now. He had not completely weaned off his ventilator. Though he's minimally conscious, want him to be weaned off in the coming weeks before thinking about a discharge. Please address my concerns as to how to deal with the situation, as he seems to progress in the right path under medical observations. His secretion management also needs to be kept in mind, apart from consciousness and ability to follow directions. They have not done much in terms of Neurostimulation or physical therapy yet? I'm awaiting your reply. We can talk briefly tonight as per our availability. Thank you so much from Ashanti. Hi Ashanti, I hope you're well. With regards to your latest email, it's good if he will be transferred into a non-COVID ICU, as he still needs ICU care. Your dad was able to be weaned from the ventilator for the past week, but needs continuous monitoring of his tolerance to do so. They need to do ongoing arterial blood gas tests and chest x-rays and monitor him clinically overall to determine if he's tolerating the weaning process and be ready to completely come off the ventilator. In regards to his atrial fibrillation, also known as AF or AFib, have they sought any cardiac consultation for his AFib? That needs to be addressed as well. He definitely needs to be stable first and eventually come off the ventilator before they talk about discharge. So I'm not too surprised that they couldn't continue today with the weaning trial if he's gone into AF or atrial fibrillation. They also need to check his electrolytes like potassium and magnesium. How else have they addressed his AFib? Have they given him medication such as digoxin, amiodarone? Have they considered a cardioversion? Those are all questions you should be asking as well. Coming back to the ventilation side of things, secretions need to be managed as well. How frequent are they doing the suctioning for him? What is his current Glasgow coma scale? And yes, he needs to start mobilizing. He needs to get physical therapy to get his function back. This can be a long process, but the sooner he can start, the better. Your dad needs to be assessed well if he's really a candidate for weaning off the ventilator, taking into account reviewing his clinical improvement with his oxygenation, ventilation status, mental status, secretions, and cardiovascular stability. If they will persist in discharging your dad too soon, you can definitely say no if he had not met the criteria. Here's the email back from Ashanti. Hi Patrick, thanks for your replies, more answers and other questions and clarifications below your comments. He has been hemodynamically stable during his ICU stay after his initial treatment and care. He is on blood pressure medications and also to control his atrial fibrillation. He had been hypertensive and diabetic for the past 2 decades. Weaning, I would say, with moderate progress. Some days he could tolerate it better than others. His kidney function has also been monitored and a diuretic 40 milligrams daily has been given through IV. That's probably Lasix. Based on his current level of progress, my guess it would take weeks to come back to say 80% of his regular breathing as a conservative estimate. Question: does he need to be in an ICU until he's on ventilation support? Can the weaning process happen in a non-ICU setting if he's, say, 50% of the time on mechanical ventilation? Please address my concerns as to how to deal with his situation, as he seems to progress in the right direction under this current medical observation. His secretion management also needs to be kept in mind, apart from consciousness and ability to follow directions. They have not done much in terms of neurostimulation or physical therapy yet. I have to check on his current suctioning interval. He might be on a 5 or 6 on the Glasgow coma scale, opening eyes only to pain or other physical movements. Left side he's paralyzed. Movement on the right side, arm and leg to pain stimulus. Yes, it appears to be a slow and long process. The hospital environment and monitoring are much better in his case. Nothing much done so far on rehab physical audiotherapy of any sort. I'm having a concern that they might simply prematurely put pressure that it would be difficult to wean him off due to his health status, and he has to be discharged with ventilation support and tube feeding to long-term nursing care with palliative care. I can say no, but will they listen towards it? On top of all of these, recently, 3 days back, I came to know that he has a palm-sized wound on his back due to laying down on his back. This is being attended by the wound care team. This might take weeks to heal fully. I felt it was negligence on their part. I cannot talk about discharge in his condition. Want to remain strong on this matter as it's unreasonable and not medically sound. Let me know. Thank you, from Ashanti. Here is my response. Hi Ashanti, the pressure sore is very concerning and potentially negligent. I agree that they need to take ownership of their potential negligence and not send him somewhere you are not feeling comfortable with. What are they doing with the wound? Is he on a vacuum assisted closure, also known as vac dressing? And no one should be going from ICU to non-ICU on a ventilator. It's as simple as that. Why am I saying that? In most countries, no one can leave ICU with a tracheostomy on the ventilator and go to a hospital for a hospital ward. In many areas in the US, patients are being sent to LTAC or subacute or a skilled nursing facility on a ventilator with a tracheostomy, but it's simply not safe. When someone is on a ventilator with a tracheostomy, they need to be looked after by ICU nursing staff, by ICU doctors. Why am I saying that? We're also providing services for intensive care at home clients, basically for long-term ventilated patients with tracheostomy at home. And we have published the mechanical home ventilation guidelines there. Go to intensivecareathome.com and click on the link for mechanical home ventilation guidelines, and clearly there. And those home mechanical ventilation guidelines are evidence-based. And the evidence clearly says that, after 20, 25 years of intensive home care nursing, of research, the only way a ventilated and tracheostomy client or patient is stable is with an intensive care nurse with a minimum of 2 years ICU experience, full stop. Got nothing to add there. Therefore, a patient can only leave intensive care if they're going home with intensive care at home, for example, but they can't be leaving ICU to another environment with the exception of intensive care at home. Everything else is not safe, and people have died if they go in an unsafe environment on ventilation with tracheostomy. Okay, carrying on with the email exchange. Ashanti writes back, "Hi Patrick, today I met with his hospital case manager and critical care specialist. Also, today was the day they allowed me to visit and see him from behind a glass door. He would be de-escalated to a non-COVID ICU due to being 20 days from his COVID admission to the hospital. Also, his bio-inflammation related to COVID is coming down. They have a wound care team to address his wound. They're using some kind of natural honey to treat it. This was reported to me 3 to 4 days back. Not sure how long it would take to heal, considering he's being in the bed most of the time. At least they are addressing it now. He was on CPAP, continuous positive airway pressure support ventilation, for 6 hours today before they put him on full ventilation support back again. This is a slight improvement overall from 3 to 4 hours from a few days ago. What do you think?" But the ICU doctor was pessimistic and kept saying that he's on a higher pressure support and he cannot wean off the ventilator as his brain function damage due to hemorrhage is irreversible. I feel that he's making little progress while being hemodynamically stable. They seem to rush to conclusions instead of looking at the positives. His secretions need attention like 1 to 2 times during the daytime and 2 to 3 times during the night. If I'm able to go and visit, he's going forward and can take a picture of his ventilator settings as well. They also wanted me to plan for his stay and care after discharge from the hospital, for which I mentioned that they can send to me, but we are far away from discharge. Your thoughts on these issues, please. It is difficult to remain positive and optimistic when they give these scary comments. I had also asked about his brain CT scan and whether it has shown any improvement. The doctor kept on saying how difficult is his situation to wean him off the ventilator. He also insisted on therapy of any sort, which they are minimally providing, if not anything. I'm awaiting your thoughts as how to proceed from ICU care, regular hospital care, and then to external long-term care. Thank you, from Ashanti. Hi Ashanti, what's his current Glasgow coma scale? Even though he's breathing on CPAP or pressure support, if the CPAP or pressure support is too high, he won't be able to come off the ventilator. Pressure support needs to be less than 8 to 10 centimeters of water with good sustainable tidal volumes, minute volumes, oxygen saturation levels, good arterial blood gases, and normal breathing rate. A picture of the ventilator would be great. Arterial blood gas results would be great also. Hospitals will continue to be negative by default because they are managing their liability. After you provide more clinical details, i.e. ventilator settings, arterial blood gases, Glasgow coma scale, etc., I will advise you of the next step. Please also again keep in mind, like I said before in my other email, the only way your dad on a ventilator with a tracheostomy can leave ICU is with services like intensive care at home that can replicate an ICU bed at home. That's the only safe option going forward if he can't be weaned off the ventilator. Ashanti writes back, "Thanks, Patrick. From what the nurses had mentioned to me, he's mostly in 5 or 6 on the Glasgow Coma scale. I will try to get a picture of his ventilator settings as soon as possible. I'm also trying to get arterial blood gas results as well. He seems to tolerate it for hours before going low on oxygen saturation. Is this normal during the weaning process? I'm kind of surprised, mildly shocked and concerned. To know about his wound on the tailbone area 4 days back from a nurse, and this seems to be a hospital negligence even in ICU care. Thank you," from Ashanti. "Hi Ashanti, it'll be difficult, although not impossible, for your dad to come off the ventilator with a Glasgow Coma scale of 5 or 6. Please get a picture of the ventilator and arterial blood gas results so we can see and review them, because only if we have both, then the picture makes sense. These are important parameters to know if he is tolerating the weaning process and hopefully to get him off the ventilator. Pressure sore stage 4, I would argue, is hospital negligence, and that should never happen. Please keep us updated." Thank you so much. The one-to-one consulting session will continue in the next week's episode. So, how can you become the best advocate for your critically ill loved one? How can you make informed decisions, get peace of mind, control power and influence quickly whilst your loved one is critically ill in intensive care? You will get to that all-important feeling of making informed decisions, get peace of mind, control, power and influence when you download your free Instant Impact Report now by entering your email below. In your free Instant Impact Report, you will learn quickly how to make informed decisions, get peace of mind, real power and real control, and how you can influence decision-making fast whilst your loved one is critically ill in intensive care. Your free Instant Impact Report gives you in-depth insight that you must know whilst your loved one is critically ill or is even dying in intensive care. Sign up and download your free Instant Impact Report now by entering your email below. In your free Instant Impact Report, you will learn how to speak the secret intensive care language so that the doctors and the nurses know straight away that you are an insider and that you know and understand what's really happening in intensive care. In your free report, you will also discover how to ask the doctors and the nurses the right questions, discover the many competing interests in intensive care and how your critically ill loved one's treatment may depend on those competing interests, how to eliminate fear, frustration, stress, struggle, and vulnerability even if your loved one is dying. You will get 5 mind-blowing tips and strategies helping you to get on the right path to making informed decisions, get peace of mind, control, power and influence in your situation. You will get real-world examples that you can easily adapt to your and your critically ill loved one's situation. How to stop being intimidated by the intensive care team and how you will be seen as equals. You will get crucial behind-the-scenes insight so that you know and understand what's really happening in intensive care and how you need to manage doctors and nurses in intensive care, and it's not what you think. Thank you for tuning into this week's Your Questions Answered episode, and I'll see you again next week in another update. Make sure you also have a look at our blog section for more tips and strategies, or simply send me an email to support@intensivecarehotline.com with your questions. Also, have a look at our membership site at intensivecaresupport.org for families of critically ill patients in intensive care. There you have access to me and my team 24 hours a day, where we answer all questions intensive care related. You can also call me, find phone numbers on the top of our website. If you want a medical record review, please contact us as well. We review medical records for families in intensive care, for patients in intensive care, but also after intensive care. Also, you can get one-to-one consulting and advocacy with over the phone, via Skype, via Zoom, or via email by clicking on the relevant tabs on the top of our website. Thanks for watching. This is Patrick Hutzel from intensivecarehotline.com, and I'll talk to you in a few days.